Good morning, everybody. Welcome to this meeting of the joint Cambridgeshire and Peterborough Health and Wellbeing Board and Integrated Care Partnership here at New Shire Hall. Just to remind colleagues that filming and photography are allowed at this meeting, so please feel free to take pictures and use social media during the meeting. Can I ask, though, that everyone present turns their mobile phone to silent, I'll follow that injunction myself, or vibrate whilst the meeting's taking place. Please be aware the meeting is being live streamed and that a recording of the meeting will be available to view on the County Council's website. There is no fire alarm scheduled for today, so if the alarm sounds, please leave by the nearest marked fire exit and assemble in the car park. The closest fire escape is through the middle doors on my left, past the water closet and the kitchen. So that's the preliminaries. For anyone else watching, I'm John O'Brien. I'm the chair of the Cambridgeshire and Peterborough Integrated Care Board, one of the co-chairs of the Joint Health and Wellbeing Board and Integrated Care Partnership. But my two co-chairs, immediately to my left, Councillor Susan van der Ven from Cambridgeshire County Council and Councillor Shabina Qayyum from Peterborough City Council. So welcome to everybody. We have a number of apologies and some changes. So I'll ask Naomi to just let us know about the apologies. Naomi, over to you.
Thanks, Chair. We've got some apologies from Dr. Jag Haluwalia, Rob Bridge, Martin Bruning, Ged Corran, John Gregg, Councillor Richard Howitt, Dr. Zoe Hutchinson, Mayor Nick Johnson, Dara Preston, Piers Ricketts, Paul Med, and Jan Thomas. Thank you, Chair.
Thank you. And I think, is it Councillor Black is attending for morning, Councillor Black, attending on behalf of Richard Howitt. And I think a welcome to all those who might be here for the first time, but in particular to Sally Cartwright, who is the new Director of Public Health for Cambridgeshire County Council. So Sally, I'm sure you will have lots to do with this board, so you're very welcome. Right, declaration. Oh, sorry, I should say on the screen we also have Julie Farrow and Mary Elford, two members of the board who are joining us remotely as well. So welcome to both Julie and Mary, both of whom I think we are going to be losing in the spring, but I think hopefully we'll see them again in March and a chance to say thank you for all the work that they've done as they move on to other things. Are there any declarations of interest, pecuniary or non-statutory disclosable interest that people want to register before we start? No, thank you very much. We're being asked to approve the minutes of the meeting on the 11th of October as an accurate record. Are there any questions or points of accuracy that people want to raise? No, thank you. Are people happy that we approve those unanimously? Thank you very much. So on to our business today. I think we've got sort of two or three main chunks. We've got the sort of first half of the meeting where we're looking at JSNAs, Joint Strategic Needs Assessments. We've got both children and young people and mental health, so two quite chunky items, but also a sort of slightly wider think piece about future of JSNAs and how we use them in terms of planning for the future. We've then got a break at about 12:15, and then in the second half of the meeting we've got some work on the Better Care Fund, both some specific work around Pathway 1, also the quarterly report, and then finally we've also got the proposition around the future pharmaceutical needs assessment. So that's the sort of nature of our business either side of the break. It's quite a chunky agenda, a lot of papers. I think on the joint strategic needs assessments, we've sort of talked about both of those before in a variety of ways because they're part of the sort of key themes of this board. So I think some of the material clearly is familiar to quite a lot of people in the room, and I've said to the presenters of both that both items that it would be good if we could fairly quickly, I think, get into discussion about sort of where we think in all of that the priorities are for us, where we want to focus our activity, rather than having an exhaustive presentation of everything that's in the papers. But clearly, if people have got specific questions, we'll try and deal with them here or separately offline. So I think that's sort of context for what we are trying to do. So I think the first item we've got this morning is the JSNA for children and young people. And can I invite Sarah Dugan to present to us? Sarah.
Thank you, Chair. I'm also joined by one of my Peterborough colleagues.
Speaker, consultant in public health, leading on children and young people.
Oh, can you get the slides up, Kate? Thanks. Oh, thank you. We will talk through very briefly the main findings of the Joint Strategic Needs Assessment for Children and Young People. While the slides are loading, we'd like to give thanks to the large number of colleagues who've been involved in this process, which when we send the slides out, if we can't get them up in time, you will see, but we've had engagement from across NHS services, from across both Cambridgeshire County Council, Peterborough County Council, district councils, and the voluntary and community sector as well. So this joint strategic needs assessment timeline, obviously you agreed as a board that we would be doing this. We developed it and then ran a stakeholder event in November 2024 with wide engagement about the recommendations. And in December 2024, we have finalised it. Just to set the scene, if we can go into slide 4, please, Kate. The population of children and young people in Cambridgeshire and Peterborough has grown and is still predicted to grow, particularly over the coming years in South Cambridgeshire with new buildings. There is, within the growth of the population, there's increasing diversity, particularly within the cities. There's more complexity in terms, for example, mental health needs. And then we also have intersectionality. So you'll find throughout all of the outcomes for children and young people, that there is the intersectionality, for example, between deprivation and free school meals and poorer outcomes. So within that context, we have 5 strategic recommendations. There's one on prevention and the best start in life, which is the next slide, please, Kate, to address the wider determinants of health and reduce child poverty, to improve children's life chances through better school attendance, something about whole system approach, particularly where we have high levels of mental health, neurodivergence and disability and adverse childhood experiences, and then strengthening our place-based offer for community services. The JSNA and its recommendations are quite long, so we're asked by the chairs, next slide please, to prioritise a shortlist. Our proposals from looking at all the data was the board could consider looking at 2 or 3 priorities for kind of system-wide working around childhood immunisations. This is because of the low uptake, around childhood obesity because of the poor outcomes associated with this, and then school readiness, especially on free school meals because of the existing Health and Wellbeing Board ambition around this, and that children on free school meals have a much lower attainment. The last 2, there was one on school attendance, given its increasing importance and the importance of reducing the number of children who are not employed or in education, which again was a Health and Wellbeing Board ambition. And then finally on mental health, which I'm sure everyone's aware has been significantly worsening and is a concern for the whole of the system. So very quickly, on the next slide, you can see the immunisations data. So 1 in 5 children are not immunised in Peterborough, which is of concern. That means 6 children in every reception class on average at age 5. On the next slide is the data for childhood obesity. You can see that more than 40% of year 6 children in the most deprived areas in Cambridgeshire and Peterborough have excess weight. It has significant impacts for their future life chances, and you can see there's a very clear health inequalities gradient. On school readiness, which is the next slide, we have, for children on free school meals, one of the lowest levels of attainment in Cambridgeshire across all 152 local authorities, and Peterborough, while it is statistically better, is still lower than average. If we move on, please, Kate. We also have seen, as people be aware from the news and other places, an increase in absenteeism in school, particularly following COVID. Again, there's large inequalities in this. We have seen the increases. We've seen a bit of a decrease in the most recent years, but children on free school meals are far more likely to be persistently absent than those who are not, again affecting their life chances. And finally, the last priority we were putting forward to be considered for the board to take forward is around mental health. Next slide. And we know that we are seeing across the NHS increased demand for mental health services with long waiting lists. We are also seeing the impact of poor mental health in schools. And the data from our school children shows that only 1 in 5 boys in year 8 and year 10 say they have good mental health, and only 7% are girls. So in summary then, we were asked to identify some of the key priorities from what is quite a long JSNA. So the question I think we would ask to discuss is which 2 or 3 system-wide priorities from this JSNA should be taken forward by the Health and Wellbeing Board. And as a reminder, the ones we thought could be the priorities for actions were childhood immunisations, childhood obesity, school readiness for children on free school meals, school absence, and then mental health and wellbeing. Or, of course, there's lots of other actions in there, so you may feel there's something else. Thank you.
Sarah, thank you very much, and thank you for delivering that so crisply for us to sort of frame that conversation about priorities. That's really helpful. Questions that people would like to raise or points on what Sarah said and what's in the children's JSNA. Susan?
Thanks. The non-professional will go first. It struck me that there are some very strong school themes, and we've seen that before, but the school readiness and the non-attendance. And it also struck me that in non-attendance, it's partially, it's so interlinked with mental health. And I would also make the observation that some of the Ofsted reports that I've seen are very interesting in terms of what they're saying about the atmospheres in terms of language and behavior and what's tolerated. And it's a reflection. Schools are also a reflection of the local community. So I'd be very interested to, I'm pleased to see these in your shortlist, and I'd be interested to hear what others have to say. Thanks.
Thank you, Susan. Comments from others? Steve.
Thank you very much, John. I just wonder if there is any correlation between children with mental health issues who then go on as young adults to have particular acute illnesses and demands upon the health service, particularly later in life, and whether that in itself might inform the priorities that we choose for children because of the impact that it is likely to have in adulthood.
Sarah, do you want to pick that up specifically? I know Mary wants to come in, but do you want to just respond specifically on Steve's question?
Well, we are going to discuss the mental health JSNA after this, but I would say that it is concerning what's happening in mental health in children at a younger age now, and we are starting to see some of the impacts beyond young adulthood. We're seeing an increase also in the number of, even in the benefits system, the number of children or young adults moving on to PIP, and of course some of that enables them to get into employment, but I think it is of concern, yes.
So I've got Mary on screen and then Neil. So Mary first.
Hello. I mean, this is obviously a very wide-ranging report, and one could pull out, I mean, in some ways, everything in it is a priority, isn't it? Which obviously makes prioritizing difficult, and I can quite see why you have drawn out the ones that you have. I guess one that always is striking to me is dentistry, and the position, particularly in areas like Wisbech in Finland, where I certainly, when I last visited our dentistry service, I don't think there were any lists in that area that were open to children. As some of you know, we provide urgent access dentistry. Have a clinic in Peterborough and also in Wisbech. So I'd just be interested to hear a little bit more about dentistry, and what the thinking is in terms of how we can improve oral health for children. The figures on immunisations are again very stark, and I'd be interested to hear, what is distinctively different in that area that is causing a lower immunisation rate than we're seeing in the rest of the county, and what thoughts might be in terms of how that situation could be improved. Thank you.
Thank you, Mary. Shall I just take Neil and then ask Sarah and colleagues to come back? Neil.
Thank you, John. So yeah, I guess I think they did a incredible job in kind of getting down to 4 or 5. I think my kind of thoughts would be, well, as we go from a long document to some priorities, what does picking a priority mean? So if something is chosen as a priority, what is different for it being a priority? Because they are all within it priorities. However, I guess the kind of the medic in me turns to things like childhood obesity, childhood well-being, and things like that. And I agree, the schools have got the fundamental place in terms of having so much contact with children. So I guess if I was to pick, I'd probably pick around those areas. If I may, just on the immunisation rate, for as long as I've been in Thistlemore, which is 15 years, we have never got anywhere close to the WHO recommended levels of immunisation. What is different? The people are different. The people are different, their choices are different, their view on life is different, their desire to have vaccines is different. If I asked everyone in this room, do you want to have a COVID vaccine? The majority of you would say yes. The majority of my patients will say no. What needs to be different in those areas is that we need to think differently, act differently, commission differently, operate differently. So, and I guess that takes me back to, well, whatever we choose, what will be different? So the health and well-being, putting its name against 3 things. What's different for those 3 things? Does it mean that funding will be going further towards those three things? In which case, I guess I would probably pick things that we think we could make a demonstrable impact, because I think our collective job is to change the outcomes for the residents of Cambridge and Peterborough.
Thank you, Neil. That's a really good challenge, I think, for when we conclude about what we're picking. Sarah, do you want to pick up the Mary's specific points about dentistry and further thoughts on immunisation? And then I've got some others who want to come in after that.
Okay, thank you. I'll hand over to Hasna for immunisations, as she's Peterborough. But on the dentistry, so there is some limited information in the full JSNA about oral health. We know oral health is far worse in children from the most deprived areas, and that's something we see across the whole of the country. There's quite a lot of interventions that can be done from a public health perspective about getting children to brush their teeth. For families that are in poverty, some areas provide toothbrushes and toothpaste. I guess on the specific issue of dentistry, that is with NHS England. And I guess if the board feels that there needs to be more work on oral health, then most areas would undertake a dedicated oral health needs assessment, working in conjunction with NHS England to understand the issues around access to dentistry.
Thank you. And maybe that Louis or Kate want to pick up on work on dentistry more widely in a moment. I've got Sally and Patrick. So Sally first.
Apologies. So I think the challenge around what does it mean to pick a priority is really helpful. And I was along similar lines, just wanted to make the point that if we're picking a priority, it doesn't mean that we're not doing anything on the others. And there will be lots of activity still focused on some of the other issues in one way or another. But I think it's maybe just defining what we mean when we're saying picking that priority. Is it about, as a partnership, we are committed to focusing much more on that as our top priority amongst all of these other things that lots of people will be doing work on as well. So I think if we can sort of shape what it means to be picking one of these priorities or two of these priorities, and then also what do we hope to achieve by doing that, I think that would be a helpful conversation to have. And also not forgetting the priorities that we have as a health and wellbeing strategy, and which then can drive improvement across those priorities in the strongest way.
Patrick.
Thanks, John. So I mean, I think it's a really good piece of work that's been done, but there's so many things within it. It's difficult to know which is the priority. And Neil makes an excellent point, really. It's about, I think if I look at the strategy, I've gone back to the 4 priorities and I'm thinking, so which one of those within the the JSNA would actually address that? And most of those could be seen to be in addressing that. And I think the question we've got to say is, how do we use all of the JSNAs? And I suppose that comes back to Val's paper later, which is around that kind of approach to the JSNA. How do we use that more intelligently to actually tackle the priorities of the Health and Wellbeing Board and do it in such a way that addresses the point that Neil makes, not kind of just become very focused and fixated on addressing dental health? Because we could say that that's a priority, and this JSNA could produce in a year's time and be saying the same things because we all feel that we've picked it as a priority, but Neil will still say that the communities and the people that we're trying to really work and change, they don't recognise that as a priority. They see other things as a priority, and that might not be around oral health. So I think we've got to use the JSNAs as a tool to help us to kind of understand where we would want to see movements and improvements around the health of our population, but focus on the priorities, but focus on something much more kind of higher level in ways in which we address that. We address it at a local level, being very clear how we're going to work with individual communities. I think just working as a JSNA at a time, because we could have the same conversation on the mental health one. So if we pick 4 priorities in the mental health one and they're different to the children's, does that mean we've then got 8 priorities? And we kind of don't really address the fundamental issues, which, and I think Neil put together so purposefully and clearly about it's actually people we've got to change, have conversations with and address things differently rather than just look at specific aspects.
Let me just, and I know Kate wants to come in, let me just check out a bit of that, Patrick. So, because I sort of think there's a lot in what you've said, I'm assuming that doesn't mean that we shouldn't look at some areas of focus today, but what effectively I think you're saying is, but that's only really the beginning of the story. How do we actually knit this together more, and how do we do the work to actually sort of, in a sense, answer Neil's question about, so what does that mean then?
Yeah, and it's not to put any criticism against the work that's been done in the JSNAs, because there's a huge amount of work being done here. But there feels that there's a suite of JSNAs, but I don't think together we are collectively looking at what the overall priority is in order to tackle them. What actions could we do that has the biggest impact on the different priorities that you would pull out from individual JSNAs?
Kate.
I think this might be an example of partnership working, because Patrick's just said a lot of what I was going to say. I think it's a brilliant piece of work and a really important document. But I think when I read through the recommendations, there is work going on in all of those areas. And the question from a board perspective should be, where are we at now? What impact is that work having? Is it the right or the wrong? Not wrong, but if it's not having the impact, how do we need to pivot? And then what comes back to this board to demonstrate that we are able to move things forward. So it's kind of, to the point Patrick made, it's it's a brilliant piece of work and gives us a huge amount of evidence, but it is also layered on historic evidence. The comment around adverse childhood incidences, experiences, ACEs, it's very well established that has a significant impact on that individual's ability to thrive in later life. I can't remember any of the stats, but they're huge when you look at the likelihood for their lives to go in different directions, that in many ways makes the case without the need for the document, that to understand how we target that, how we even just are aware of our levels of that as a system as well, and kind of how that feedback loop works for that information. So I think it's a really exciting document, but I think the jumping off point that would be nice to use all of the JSNAs for is to kind of consolidate the what are we doing and how are we overseeing the impact of that, so that we can learn from it and pivot if we need to do something slightly different.
Thank you. Louis, and then I'll bring Susan in. Louis.
Thank you, John. I won't repeat what others have said, because I think some really good points made around how we prioritize, and as Kate said, what's already in place. I agree it's a really good piece of work, and I think there's nothing really to disagree with in terms of the actions. The bit that I was wondering about is whether we've got enough information to understand some of the drivers behind some of these outcomes, because what this report is telling us is we're not doing, the best for our children, we're not achieving the outcomes. We've had conversations, haven't we, around actually the power of sort of combining our intelligence, for example, because a child not going to school may be because actually a parent need help. It may be because of a lot of other factors that this is telling us isn't happening. But actually, if we are starting, as I think, as a public sector, to combine some of our intelligence, also understand more about the risk of an individual, the risk of a family, what is really driving the outcomes, I think they could do a lot more in terms of intervening in that as a crisis. And I think some of the high intensity work that we're doing is an example of that. Actually, those kind of the joined up approach to getting people out of crisis, for example, and it won't be different for a lot of these indicators. And I think just another thought maybe to think about is actually really, really helpful to see that, the data and the indicators and the actions, but there's probably a lot more that we can do to understand the drivers.
Louis, just while you've got the microphone, I don't want to break the thread of this too much, but do you just want to give us 3 or 4 sentences on dentistry just to complete that bit of it if people were left hanging?
Absolutely. So obviously, previously commissioned by NHS England, now sort of coming to ICBs. We've got a significant amount of work to do on dentistry and access. And the first piece of work that we are doing is to understand some of, again, the drivers behind why we are where we are, and doing a real diagnostic. And we're working with dentists to understand, what is causing people to hand back their NHS contracts, what's wrong, what's not working at the moment. But there is a very specific piece of work also on pediatric dentistry. And so I think, again, a reflection on what Kate said is, a lot of this is things that we are in the process of, 1, trying to understand and diagnosing, and then 2, working out how we address that. And I think some of that we need to reflect in the priorities as well.
Thank you. I've got Susan and then Mike.
Thank you. It just occurs to me that, well, firstly, the actions are incredibly helpful. But there are probably obstacles within those actions that we as individual organizations probably recognize within ourselves. Just to pick one, the best start in life, the underpinning by effective, simple information sharing. Well, that sounds good, but we probably have examples where this is not happening. So an awareness of points within actions that actually need to be addressed across our partnership. Thanks.
Thank you. Mike.
Yes, I agree with a lot of the comments that have been said. I'm going to say something which is so obvious that it hasn't actually been mentioned, which is that particularly with children and young people, we have a safeguarding duty. And I think that one way the board can work out which priority, I would suggest that given there is so much going on, we try and pick one priority that we as a board would like to be assured of progress upon. And if we look across those priorities, I think that the mental health issue and the school absence issues, they're linked, is a concern when it comes to, are those children who are not attending school safe? I also think that we can't change other people. We can't probably just pump more money in. What we can ask ourselves is, are we using the funds that we are actually, it's the ICB and it's the local authorities should actually look at could we use our money, are we using our funds in the most optimal way? And I think there's a question about, whether closer, more integrated commissioning of those funds is a way forward or not. I don't want to kick the ball into the long grass and have a year to think about whether we want to set up joint commissioning, but some sort of fairly rapid appraisal, maybe asking some of people themselves and their representatives, is there any obvious waste? Is there any obvious duplication in terms of what we're doing to keep our children safe?
Thank you. Thank you, Mike. Stephen, and then I'll come back to Sarah. Steve.
I think just building on that point, really, I think Louis' point around understanding data and really understanding the issues. So I think around kind of neurodiversity and children coming into adulthood, it's probably for us in adult social care, it's probably the biggest single issue is that issue of children coming through who we just didn't know in the system until they kind of hit adulthood or maybe leave education and then don't go into employment and are then in a situation where structure's gone from their lives and things start to go really badly for them. So there probably is something about a priority area around looking at the kind of the data. I think we're doing quite a lot, aren't we, around the kind of predictive analytics type stuff and really understanding the full range of data that we have. I wonder if that's a kind of a real priority area for us in terms of just doing that investigative work around what data is available to us. How can we start to predict? Because there's a lot you can do in terms of kind of neurodivergency and stuff. Kids who are getting by at school, a bit of work around employment skills and stuff at the right age could really kind of prevent quite a long time in a health and care system that I think people are unnecessarily having in adulthood. But it feels, in terms of the work I think we're all looking to do, isn't it, around predictive analytics, a real area that would add kind of an enormous amount of value. So I wonder whether it is an area we want to kind of prioritise.
Thanks, Stephen. Neil.
So I think I've been in the system now for about 15 years. And what's brilliant about being in the system for 15 years is that you kind of hit, I think the rhetoric has been the same throughout the whole of that 15 years. The population's getting older, the population's getting bigger, the population is diverse, the population have got different challenges in different parts of it. And so I guess the bit is with the, and it's not to go against Steve, but the data is the data, right? This data, we know the populations of Cambridge and Peterborough, but what are we doing about it? And I guess for me, this is the joint health and wellbeing and ICB board. We have got all of the commissioners around the table. We've got the majority of the providers and the voluntary sector around the table. I think the job of this is to go, well, if we're going to pick something, whatever it might be, what is the resourced plan that the Health and Wellbeing Board wants to oversee in this system? What are the priorities? What are we going to measure? Not too much data. In Cambridgeshire, we spend a lot of time on data, okay? What are we actually going to do that is different for the residents? How are we going to track progress on one or two things? And I think that's what we don't do in our system well enough. Yeah, we talk about the big, massive challenges that are there, but we don't do the step-by-step kind of innovation and iteration and experimentation. Childhood immunizations, although I say, look, I've never met my targets, I'm still working really closely with the ICB. We're still trying innovative stuff. We're still trying drop-in clinics, Saturday clinics. It doesn't stop us working on this stuff, but actually it does take resource, energy, effort. And I'd say to the Health and Wellbeing Board that what we should be doing is picking one or two items and having a resource plan that focuses on changing the outcomes for the residents of Cambridge and Peterborough.
Thank you, Neil. just going to give Sarah the chance to come back on anything she's heard, and then I'm going to sort of ask Sally to sort of come in, and then we'll try and shape about sort of where we are and what we're concluding. So Sarah.
So I agree with all the comments. It is a very big document, isn't it? And there's a lot in there. Some of it is because the JSNA should be used by all the commissioners across the system to direct their work. So it does have another purpose than obviously it has to come to the statutory board. I understand the desire to map out what we're doing across all of this. I think that will be a huge amount of work. And we may never emerge from that because there is, as people said, there's so much work. There's so much going on across different parts of this system that it would be huge and out of date very quickly. So I agree it would be good at a health and wellbeing board level to look at a couple of priorities where that more in-depth work can be done, and where you could start looking at the resourcing plans and how all system partners work together to make the change.
Thank you. Sally.
So I completely agree with that last point around if we want to look at the service, what's already happening, what are we doing, what's working, what isn't working, then I think we do need to focus on one area to do that as a system. You know, different teams will be doing that as they're developing their strategies and commissioning plans on different issues. But if we as a whole partnership want to come together on one of these priorities, I think that would be a good way of doing that. So say we were picking the obesity priority, for example, we could then come together in a sort of workshop setting and really think about what does that mean, how are we really going to focus on that as a system, and what's already happening, what isn't working, what does the data show. So I think doing that approach might be helpful. I just also wanted to endorse that point around some of the analytics and thinking about how we can collectively think about what data we have, how we can link it, what architecture we might need to be able to do that in a cleverer way to be able to inform some of this work in a much more specified way. Because then you can start to think about particular target cohorts, particular interventions that really drive change, because we know the drivers and we know the risk profile of different groups of individuals. So I think just an endorsement and recognition that some of those comments I would really support as well.
Thank you. So I think where it feels like we've ended up, but let me sort of check in with people on this. Picking some key areas of focus doesn't mean to say that other things are not going to be happening. Of course they are. Secondly, I sort of entirely take the point that both Neil and Patrick made, that actually this sort of prompts us more widely to think about sort of what's the nature of this? What does it mean if we pick some key areas of focus or key areas of priority? How does it relate to other things that we are doing from other JSNAs or other work that we're doing? How does it link to the key objectives of the overall health and wellbeing strategy and ICP strategy? So, you know, we clearly need to do some work, I think, to sort of knit those together, and that in all of that, we should be looking at opportunities in the way that Mike said about, well, what are the opportunities around how we commission jointly? Stephen's point about, are we looking properly at data and analytics and how we sort of bed that into the work? So I think there's sort of a number of other questions that have been begged as a result of this, which are sort of looking at Sally and Mike and Patrick and Kate and colleagues. You know, I think we probably do need to do some more work on so that the board can actually put that into the wider context. It doesn't absolve us of the need, I think, but hear what people think, to sort of think, are there one or two things here then that in particular, as a result of the valuable work that Sally and colleagues have done on this JSNA, that we really would like to see some focus and energy on? And I suppose I've heard two sort of big themes, one about the mental health one. The other, I think, is probably in the sort of wider area of potentially prevention, wider determinants of health, the point Sally just made about obesity. So let me take a check-in about whether that's the right place to land, and if so, what are people's views about where in the short term, notwithstanding that wider context, we'd like to see some focused effort for us to take forward collectively. I'm not going to make people vote, but nonetheless, some views would be helpful.
I just, on reflection of the priorities, I do wonder whether mental health might help us get some traction against some of the mental health issues that we're seeing, which is it can be quite difficult to make tangible what actually we're doing around that for young people. So it might help to have a real focus to coalesce around that from this work, potentially.
Patrick?
Yeah, thank you. Yeah, I'm with Sally on that. I think the mental health one, given when you read through the paper, how much links across to the JSNA and the mental health one, and we know from an adult's perspective the continuing pressures we see on the mental health services. So I think mental health would certainly be one. I suppose the one that isn't there pulled out, which is a lot around kind of immunisation, oral health, and school absences, is where our focus is towards parents, and how do we see some of these priorities from a support to parents perspective, because children in their own right may not make these decisions. There might be it's often around how the influence and strong parenting is, and I can see it in parts around, I could see in action 3.5 around the expertise of parents in relation to support and needs of children, but I just wonder whether or not there is something about how do we think around, how we link in with the work we're doing in our Healthy Scales programme and the connections with parenting programmes and from children's services. So there's probably a little connectivity there, but certainly they would be another bit that you would want to group together around immunisation, obesity, oral health, etc.
Kate?
Can I just second that? Because I also think it would be useful with working through the priorities to also link to some of the more foundational work that's going on at place and at neighbourhood level as well, looking at John sitting in the audience, Neil's around the table, but looking at how we are wrapping around families and parents, so working with the families and community teams in our district boroughs, etc., etc. So I think that would, not to nail any of that now, but I think there'll be more probably intelligence and learning that we can kind of pull together about how we look at data collectively, but also how we try and reduce duplication or siloed working when we're supporting families and parents, and understanding the impact, that ripple effect that has on the children that they're responsible for as well.
Just something about being a bit more specific around when we say mental health, because it's such an enormous area, isn't it, that covers so much. So being a bit more kind of specific around where we think we can really add value, I think, for children, isn't it? Because I just think we get a bit lost, don't we, in kind of overall coverage.
Yeah, I mean, I'm sort of assuming that the subsections within the paper are probably where people want to focus, but I recognise that, of course, as you develop it, you need to do that more specifically. Sorry, well, I've got Neil. Well, can I take Mary and then Neil? Mary.
Yeah, I just really wanted to give my support to what Kate and also the colleague who spoke before her said about a family focus and using data in a more intelligent way around the family group and the environment within which children live. I think firstly, I know certainly Norfolk Council, which is another ICB that we work with, are doing a lot of work around that at the moment. Just in terms of how data is grouped around the family. But I think the other part of it is also that it's the building trust, and I think what we're just seeing is so many families for whatever reason have lost some of their trust in both health professionals, but also schools and other professionals, and exploring ways in which that trust can be built and maintained is so vital to then the health that child, the healthy environment within which that child lives. So really support that approach. Thank you.
Thank you, Mary. I'm going to take Neil, and then I'm going to bring us to a conclusion on this. Neil.
Yeah, I guess my reflections would be that maybe if this had come to places like the North Place, South Place, discussed there with partners, and views brought then to the table, it might have allowed a pre-digestion of the information and goal setting. Because I think potentially the trouble is that we ad hocly agree to some priorities here. I mean, everything that's been discussed, I completely agree with. So I've got no problems with any of the things that have been discussed before. And I guess, just my own process of thinking through this is that maybe, Kate's right, that actually the answer is what are we doing in communities, neighborhoods, local infrastructure to make this happen? And I think that's the missing link currently. I think I always have a challenge with, it's got to be system, it's got to be big, of course, but it's all about the people. So how do you marry up the big strategic issues that have been here for my 15 years? All of these issues we've discussed today, they've been here for all of those 15 years. Yet none of them are new. And so, but I guess what I am aching for is progress on these issues. So what is the enablement of progress on these issues? And I think Kate's articulated it well, which is we lean on neighborhoods, communities, place to actually help us, and then we as a health wellbeing board set the objectives of what we want to do, what we want to see, how we're going to measure it, and then ask for reports on progress. I think that is the future.
Thank you, Neil. That's really helpful. So I think this conversation has been really helpful in a way that wouldn't necessarily have been entirely anticipated from the paper, which is that it sort of raised that wider set of questions. And I think we are asking colleagues, Sally and Mike, Kate and Patrick, to have a think about what that means about sort of what do we mean by priorities, how do we actually get some connection across our different areas of priority. So I think that needs to happen regardless. And I think in March, we've got some time to do a slightly more reflective session in any case. So perhaps when we have that conversation, we can think about how we take that forward. And that would include, I think, the point about what is the role of place and how do we work with place partnerships, and Neil's point about pre-digestion. So we'll need to craft some, I think, a sort of resolution out of this, which we'll look to officer colleagues to help us with, but in that regard. On the specific of this, I think what I've heard is two things: that mental health, taking Stephen's point, we need to be more specific, but there are some sort of issues within the paper that looks like one area where we should focus and concert our efforts to test this out as a way of working. There is, though, I think that second theme, which is slightly different, but is, I suppose, that whole point about how do we link this to people and communities and place, and the point that Mary made about families, to picking up on Kate's point. So I think that that's the sort of second thing that we need to work through. It may be linked to that first point, but the mental health one plus that, it seems to me, is probably where people have ended up around the room. So if there's any dissent to that, please say so. But I think that's probably the best we can do in terms of this conversation this morning, in terms of sort of saying, well, here's something specific. Here's a wider point that we've all alighted on different ways, but how does that link to our way of working? I'll just pause briefly, ask Sally, Mike, whether that, from an officer point of view, does that seem like a reasonable way forward, thinking ahead to our session in March?
I think it does. I was just thinking as you were talking, and I'm still getting up to speed on the infrastructure of the strategic approach here. But where we've got for the health and wellbeing strategy, ICP strategy, the 4 priorities overarching, the infrastructure that there is in place to take those forward with senior responsible officers, and whether there's working groups that happen to drive those forward outside of these meetings, I'm not fully up to speed with as yet. But whatever infrastructure there is around that should help drive this forward. So if there's a working group for the children and young people's one or the mental health one, then perhaps we should be asking them to drive.
Thank you. Well, we'll say look to you and colleagues to sort of, I think, have a think about that. And as I say, we'll come back to that in March. So I think that's what we are. I won't go through the sort of recommendations as on paper, because I think we've slightly modified them, but we can, I think, got a sense of what we're doing. Sarah, thank you very much for the work, and Afsima and colleagues. Can I move us on then to the mental health JSNA? And we've got Kathy and Eleanor, I think, who are joining us. Kathy, over to you first.
I'll try this one. Can everyone hear me? Right, so I'll just introduce myself. I'm Kathy Hartley, consultant in public health at Peterborough City Council, and I brought Eleanor Tovey here with me. Eleanor is our public mental health manager across Cambridgeshire and Peterborough, and did the groundwork, or all of the work, I should say, almost, for the mental health needs assessment and JSNA. I have to say, actually, the work was done in collaboration and very much a partnership piece of work across the system for the last 2 years, and it was started off as a needs assessment, and particularly involved was our colleague, public health consultant Catherine Faulkner from CPFT. So, like I said, the JSNA built upon a needs assessment, mental health needs assessment, which is being published chapter by chapter online through Cambridgeshire Insights. And this really was an in-depth analysis of understanding the mental health needs of our population across Cambridgeshire and Peterborough. And it is chapter by chapter, and you can have a look at the resources online. And based on the full needs assessment, we then decided to write we were tasked to write a JSNA to pull out the main recommendations. So this was to work with the system, particularly on the highest level recommendations for the system with the biggest impact. So we took in total of 266 recommendations across the whole of the needs assessment, and then looked at the system-wide recommendations and have 15 of those. We did this by engaging with stakeholders all throughout, actually, the needs assessment. We've engaged with stakeholders across our whole pathway of care, including sort of the NHS colleagues, local authority, community sector, and people with lived experience of mental health problems. So there are 15 recommendations. If you can go onto that slide, please, Kate, which is the next one. So as a result, and this dovetails with the conversation that we've just had for the children and young people's JSNA, basically, and also how do we prioritize? How do we really pick out some of these priorities and what to prioritize on? But on the screen now are the 15 top-level system-wide recommendations for the mental health JSNA. And you can all have a look at those, but I'm going to just highlight the ones that are in bold in the next few slides. So the first one I want to just highlight to you is how we commit to parity of esteem between mental health and physical health. This is an ongoing long-term issue that mental health is not given the parity with physical health. And that's through, we can observe this through the lack of access to treatments for people with mental health conditions compared to with physical health conditions, and the lower level of overall funding for mental health services related to that level of need. And also, if you look at this is demonstrated by the waiting lists, for example, with people with mental health problems compared to physical health. So there's a significant unmet need for individuals, families, and communities for mental health. The next highlighted recommendation is that we know that poverty is one of the biggest drivers for poor mental health. So as a system, how do we work across our system, and what do we look and learn from the work that's already being done, and how do we work together collectively to address poverty in Cambridgeshire and Peterborough? Knowing that this is a growing issue at the moment, and there are a lot of particularly children and families living in disadvantage, and particularly in areas, inner city areas, for example, in Peterborough. The next slide is linked to the poverty, is how do we address the wider determinants of mental health? So we again know that some of the driving factors are things like education, employment, housing, and these will drive our health outcomes, including mental health. So we do need to have action across our system in terms of addressing the wider determinants of health. And one way to do this as a system, and I emphasize this to the board, is that we could look at how we collectively become anchor institutions and networks of anchor institutions, to look at how we connect with our communities and our and offer what we can offer to the communities to address some of the wider determinants of health through being anchor institutions and what that means. And we can go into that in more detail. The next point I wanted to pull out is around inequalities for mental health, particularly to strengthen the anti-racism agenda. We know that there's been decades of research highlighting ethnic inequalities across the mental health system. So to tackle racism, and that's culturally, institutionally, structurally, and within our communities, should be a priority for the system. And the graph on the right shows that the difference in this is basically detentions under the Mental Health Act, and you can see the difference by ethnicity and how why we need to address this issue particularly. The next slide I want to go on emphasizes what we've just been talking about for children and young people, and the particular need to address mental health, especially in young adults. So at the moment, there is a wide range recommendation to have a 0 to 25 service for mental health. And at the moment, we're not doing this. There's a drop-off in our system when children reach the age of between 16 and 18. And it's really, the services are not fit for purpose for those younger adults. And we know that a lot of the mental health need establishes during this time. A lot of the issues for mental health establish before the age of 25. And then lastly, I just wanted to emphasize that we shouldn't forget about older people and the mental health needs that they have. And particularly that older people do not receive the same attention as working age adults in the community mental health transformation. Many of the services just do not support those aged 65. They're not age appropriate for mental health support. And I'll end there because I want to have a wider discussion from you all about how we prioritize this work.
Thank you very much, Kathy, and to Eleanor for the work. So I'll invite people to come in. I mean, just to say, I think that clearly there's a whole set of similar issues to what we discussed before about what this reveals about how we need to get into these. We might pick some of it up in Val's paper in a little while, but also in terms of how we bring some of those themes together in the way we said earlier on. I suppose my sort of initial reaction, but invite views from around the table, is that I can sort of see all of these as big existential questions, things like parity of esteem, but we're very well aware of. I'm struggling a bit more to get to, is there something very specific and actionable that we think as a system we could congregate around? But it may be that I'm missing some of that and others may have a view. But let's take some responses and reactions. Susan, do you want to? Oh, sorry, Shabina, big pardon.
Thank you, Kathy. And you know that we've been in conversation around sort of a mental health approach with reference to Peterborough as a city. I appreciate the statistics that have come forth. I do think in terms of becoming drivers for those change, it's really important to see meaningful impact as well. And by that, it's sort of aligned with what Neil has just said in the previous issue. Will we be sitting here in 3 years' time talking again? How do we enforce these changes? And part of that is we've certainly spoken in Peterborough about public health, and I think part of that should be our mental health strategy, speaking to every single directorate within the council. We all know that from an individual perspective, health and well-being particularly affects every single facet of society. How are we reflecting that in our own strategy from not just a public health point of view, but from every single directorate. And that's part of our vision, especially with reference to Peterborough. How do we direct that vision across the county and implement it within different directorates as well? So I don't see much about employment over here. I think that we do need to start talking to talk about having or formalizing things like mental health charters where authorities are speaking to local businesses. And we all know that people who work on a daily basis, we've seen a high level of people who sign off sick from work because of mental health problems or mental health associated illness. I think that that's an area that probably needs to be looked at as well in order to improve the figures that you've just highlighted too. It's just a point that I wanted to raise. Thank you.
Thank you, Shamina. Others want to come in? Liz?
Thank you, and through you, Chair. Thank you for the work. I feel a little bit uncomfortable because I think this is the third meeting I've been in 2 weeks when I've been asked about what the priorities are in various areas of health and well-being. And, you know, as others have said before on the previous agenda item, it feels a little bit like we are kind of being sort of blowing around in the wind a little bit. And somehow I think we need to land these discussions. But I wanted to focus specifically on one thing which you mentioned, which was anchor institutions. And we've been talking about anchor. So for people who aren't familiar, anchor institutions are those large organisations in the public sector who are able to provide employment to people who may otherwise struggle to get it, my understanding anyway. And we have been talking about that, certainly in the kind of local government sector for years. And it feels like it's a no-brainer. And I guess, you know, we need to look at why isn't it happening? And my feeling is it's because we haven't resourced it. So everybody thinks it's the right thing to do, and everybody has capacity in their, you know, in my organisation, I have capacity to make it happen, but I need some support to do it. And I guess with all of these things, it's about how are we resourcing it rather than just talking about it, because it seems like the right thing to do. And that's I think, you know, where we're struggling as a system.
Thank you, Liz. Kate?
Just building on Liz's point, and it links to the conversation we had previously. I think where we've got pieces of work like that. So Charlotte Williams was here from NWAFT. She is a huge advocate of the anchor institution, and she's newish, probably April, I think, newish to the system, and she's trying to kind of pull that into a piece of work, the body of work. I think as a system, one of our challenges is how we do that connectivity and that communication piece so that we're really clear on, and it's not about mapping every single piece of work that's going on, but it's about being able to, Liz's point, have kind of a resourced approach to pulling some of this out of the ground and it becoming part of our overarching identity, but also us then being able to understand the impact that it has. I think Neil articulated it well earlier. That's kind of the bit that's missing. I think there's so much in this report that, again, is a known. It's something we've known for a very long time. And I think from a board perspective, we need to, and this is something for the officers to take away, and John and I have already sort of spoken about it, and some of the other officers also, you need the engine room to be able to kind of pull some of this together to then be able to come back to the board with, this is what's happening, or these are the gaps, and this is where we need your specific attention. So endorse the report, and there's some brilliant stuff in there, but I think it's a similar set of comments, because I think I know of work in loads of those areas, and I also know of challenges that I would like to see answers to, which we're working through at the moment, but it's how you get that visibility and join up in that kind of messaging and oversight.
Thank you, Kate. Patrick?
Thank you. Just to build on the previous item and the conversations there, I was just looking through this kind of system recommendations, which are extensive, and just trying to think through, you know, what we already on with elsewhere that we could tie this into. So, you know, I mean, the parative esteem is something that I'm sure we would all support, and, you know, people you will work with who have poor mental health, or from personal experience, yeah, the parity of esteem's fine, but often funding drives down where the focus is of attention, and it's often to physical rather than mental health. I think the role of councils, particularly, and the role of districts in their kind of leisure facilities is critical around how we can support people around making sure that their physical health is maximised and supporting people into physical health. I think the workforce plan around people with mental health, we've got that's a huge agenda. We've got the work well agenda, but we've also got the role of the combined authority and the skills agenda, and where the combined authority and where are we asking them for that focus around the skills agenda. And we've done a quality of life survey, haven't we, across Cambridgeshire, and often what comes and manifests itself as people feeling lonely, particularly younger adults feeling lonely. Often loneliness can lead to poor mental health, and I think we've got to understand what the role of the voluntary community sector around supporting people. Back at Kate's point, which is around the locality and the neighbourhood perspective of, what's the role of our voluntary community sector, and more universal services that can really get people and find a route for people at an earlier stage, and people identifying on their, if they're reaching crisis, what are their mechanisms that they can access and support. So I do think I don't think we could argue with any of the recommendations here. Some of them are quite significant, and whether or not you could commit to those really effectively and prove in a 12 months time that you've moved forward on it. But I also think we need to think about organisations or system work that's already underway that we would tag these into to say, how do we evidence that they're having an impact on these recommendations?
Thanks, Patrick. So I've got 2 or 3 others want to come in, but just to check, in effect, you're saying pick those areas where it's most obviously where we have got to collaborate across the system. Picks up a bit of Liz's point about anchor institutions, and really think about how we drive the value out of those.
Yeah, I think if we went through here, there are already parts of our system, if not significant parts of our system, that have on their agenda priorities which could address some of these recommendations. And I think it's making sure that they are acutely aware of what the Health and Wellbeing Board are agreeing, and how they can evidence work towards delivering on that and show a significant movement on that as an improvement.
That's helpful, thank you. I've got Neil, Mike, and then Steve. So Neil first.
I've got an app called Speechify, so I listened to the papers. So I listened to this paper and the last paper, and as I listened to the papers, I thought there was a great synergy between the two JSNAs, and they articulated the problem really well. I guess, so as a clinician in the system, one of the biggest challenges that we do have is waiting times and criteria for referral. So that was brought out in the JSNA, which was that a lot of the referrals that go in don't get accepted by onward services, and also people that are on pathways are waiting a really long time. And I guess if you think about around the room, if you've got children yourself, or if you've got someone experiencing health needs or anything like that, it's often the waiting that's the worst time, because actually a problem's been identified, but actually you don't know if it is a diagnosis or not, and things like that. And so, I do feel that within this one, it is probably trying to be really honest about what we think a waiting time should be for services, and actually is that, do we have a harder outcome on here, which is actually that we would want these. So I guess where I'm coming from is a lot of the rhetoric at the moment is that, the country is recovering from the COVID-19 pandemic, but how long are we going to talk about the COVID-19 pandemic? When are we going to say, well, actually, services should be responsive, waiting time should be to a certain standard? And if it's a resource issue, then actually, how do we as a system think about how we put resource into areas to get them back to the standards that we'd want for our own families and our own children?
Thank you, Neil. Mike.
So I wanted to make a suggestion which is linked back to our previous discussion, and the area of mental health is something that there are very many groups. Every organisation represented around this table has mental health as a priority. So I think the question is, what can this board do that no one else can do, or what's the unique contribution that we can make as a health and wellbeing board? And then I want to go back to a suggestion that was made for the children's, that maybe there's something about picking just one thing and asking for our colleagues who are responsible for place-based working and for individual organisations, actually what they're doing about this and coming back to that as a board in 6 months' time and in 12 months' time, and as it were, not holding to account or understanding what the struggles are which are making it so difficult for there to be a place and neighbourhood based response. I don't everyone's trying their hardest already. I think as a board what we can do is listen to the messages that come back when we put a challenge to our integrated neighbourhoods, to our local authorities and their subgroups. The area which the recommendation which I personally would pick is the one about poverty. And I haven't got the wording absolutely in front of me as I speak, but it's something about ensuring that poverty is not a disadvantage to accessing services. I think that could also be linked to what Neil was saying about waiting. And I think there's a concept which comes in the new model of care, which is about healthy waiting. So what are you doing as an integrated neighbourhood, as a local authority, as the voluntary sector, to enable people who are waiting for access to mental health services to do that in the most positive way that they can?
Thank you, Mike. I've got Steve, Louis, and then Susan. So, Steve.
Thank you, John. I like the report, and it's hard to disagree, I think, with any of the recommendations in there. But I wanted to come back to this point of being an anchor institution. My own organisation takes very seriously our anchor responsibilities for wanting to promote and support the general health and well-being of the populations that we serve. But I think the challenge is to go beyond the sentiment of that and the moral responsibility that we have as a large public sector employer. And as some colleagues around the table have suggested, how do we actually give that sentiment practical effect? Because there'll be no change unless we're able to give it practical effect. And it strikes me that as an acute healthcare provider, there is a strong business case within this as well, because if we are investing properly in the health and well-being of our local populations, that in itself will help to reduce demand for some of the acute services that we provide. The challenge, I think, for all of us is to go beyond agreeing, as we do at all of these meetings, with the sentiments of what's in these papers and so on, and actually doing something practical on the ground that makes a real difference. And as Neil has suggested, that we have the means of assessing and taking assurance that that practical action we're taking is actually having an impact. And I think the second area where we need to be much braver than we are now is to actually free up resource to go behind the commitments that we're making around this table. So for me, within an acute trust, how do I move some of that ring fence resource to invest further upstream in delivering some of these priorities?
No, that's a very good challenge. Thank you, Steve. Louis, and then Susan, and then we'll see where we're fixed. Louis.
Slightly different direction. I just wanted to raise a couple of points. I think, first of all, I think we need to acknowledge that physical health also impacts on mental health. And I think, palliative esteem is really important, but we hear from patients all the time, about some of the long waits that they are seeing, that we're seeing in physical health as well, having a very significant impact on their mental health. So we just shouldn't forget that link. I was really struck by, I think, the comment that Mike made earlier, which is, understanding what we are spending money on and whether that is actually achieving the sort of outcomes that we want. And I think it links to the point that Sabina made as well. But we do need to understand that. But I think there's something fundamental about how we also offer services differently to patients. And if I think particularly in this sort of CYP mental health space, we've got to acknowledge the fact that our young people want to consume services very, very differently to what we've historically offered. And it isn't to be just in a long waiting list, to see a counsellor. There's so much that we can do, so many things out there that we could use to offer services to our children and young people in the way that they want to consume it. And fundamentally, what we want to try and do is prevent as much of that kind of later escalation as we can by offering it much earlier on in the process. And we're actively looking at a few tools now to be able to do that. So I just want to say, I think it is about, investment. It is also about how we make sure that that works. It is about changing our service provision to the population. But I think that link for me between mental and physical is really important.
Thank you, Louis. Susan.
Thanks. I know it's a coincidence that we've had both of these JSNAs today, but we did acknowledge in the first discussion how deeply the CYP JSNA intertwines with mental health. And I felt we did begin to focus on a potential action plan, where we could actually make a difference, a contribution, and do something creative around communities. I think we need the word and parents and families. And we have lots of rules around for the Health and Wellbeing Board. We don't have as many rules for the ICP. And we did decide to come together and do things, in a new way. Is there anything precluding us from having a single action plan for the two JSNAs to combine? It feels to me it's just a constant overlap, and that the outcome we chose on the first JSNA is very much about mental health. So could we put our resource into really shaping that a piece of work, is my question.
Any immediate answers to Susan's question, Sally?
I don't know what the answer is around, would we be allowed to do that? Can we do that as a system? But my immediate thought was, if we did do that, then we would be mostly focusing on children, young people, and the mental health elements of that, and the bits around, unless I've misunderstood, looking, the bits around the anchor institutions, the employment and health, and work and mental health, and those bits where we could really influence as organizations might get missed, unless I've misunderstood what you were saying.
Actually, I guess what I found very interesting about that one was the role of the community and families and parents for children. And so I do see it, and I'm sure the integrated neighborhoods in North and South Place, that whole place working is about people and communities. And so I wouldn't envisage it as a kind of an isolated focus on that, on an age group.
So I think again it's thrown up sort of some of the questions we had before, and Liz is right to, I think, talk about discomfort, because I think we probably feel some of that collectively about how do we fuse this together, not just in the ways we've just been describing, but also with the broader priorities we have. As I say, I think there is a plan to do a sort of a longer development session in March. So I think probably we'd be looking to try and pick up quite a few of the themes of this wider conversation as part of that, about how we work. And I think the sort of question that's been asked about both, about, so what does it mean? What does being a priority actually mean? And how do we mobilize some resource around it? Unless people feel differently, I don't feel comfortable saying that we've sort of got to a point where we know exactly what the priority is from this paper. And I sort of think that there's been quite a lot of range of views, but I do sort of take the point that there's quite a strong linkage to that second theme we described earlier about what does this mean in place and neighbourhood and how we link to families and communities. I think there's also a very strong point about anchor institutions, and the point that Patrick made about there's a lot of stuff that's already going on where we are working together, and actually we should look hard about, in the context of this paper and these recommendations, what can we pick out that therefore would become sort of critical to that. And I sort of feel that there's some more work that needs to be done to get to that place pretty quickly, because we've got the paper, we've got the JSNA. I don't think we need to do it to death, but I sort of feel it needs to be in the context of that wider conversation when we come back next time. But by all means, tell me that that's not right, and there's some stuff that people immediately think we've agreed on. But I think I would urge colleagues, and maybe the three of us as co-chairs need to have the conversation with the officer team about how we actually sort of crystallise some of that for when we come back next time. I don't know, Susan or Shabina, whether that seems reasonable to you. So I think, as I say, lots of people have said there's lots of material in here that is really valuable and worthwhile, but how do we make some of that real, and how do we link it to our wider conversation? So I think that's the nature of the conclusion we've reached. Kathy, Eleanor, thank you very much for the work and getting us to this place, and we need to sort of move on from there. So thank you. Can I ask Val to join us on the sort of wider JSNA development point? And I guess quite a lot of the conversation we've had, Val, is sort of relevant to themes that you want to pick up on. I'm sort of conscious that we've overrun a bit, but it'd be helpful, I think, then that would, in a sense, finish off the nature of this conversation about what it means and also what it means for the board. And then we'll take a break. So Val, over to you.
Yes, and I suppose I should say thank you, because I think you've actually done my paper for me in many ways. So thank you for that. So therefore, I hope the recommendations will resonate with you as well. The board, I think probably this paper, the origins of this paper reflect what many of you have said, and which Neil articulated very clearly, that when you've been around in this system for a while, you see the JSNAs coming back again, and they're basically saying the same thing. And I think that's probably been a big driver of this paper. Getting back to the paper, there are 5 main recommendations, and there are a few main themes in there. One about the practicalities in terms of as we go forward. We've come to the end of the current recommended approved JSNAs, and we normally then set a new schedule. The second theme is how JSNAs are produced, giving the organisational landscape changes and the opportunities and the things we need to work through. And then lastly, it's very much that's been the theme of all the discussions. And it's really nice how the discussion moved through into actions. And I think that recommendation about providing space in this committee to explore what the JSNAs are saying and what it means for the system. So those 3 themes that you picked up on repeatedly would be prioritisation, the synergies, and then translating those into actions. Very briefly, because I'm aware of time, the recommended JSNA, that's a hard one to say, JSNA areas, got it there eventually. Those 4 that are recommended, I think, probably reflect some of the discussion around prioritisation in terms of reflect that areas, quite simply, perhaps we haven't covered or haven't done for quite a while. They reflect the wider strategic landscape, and also it picks up on some of those areas which cut across all the areas, and some of those pressing kind of strategic levers that are coming down from national level as well. So I think probably housing, you say, yes, housing and health links, yep. But in terms that we are one of the biggest growth areas in the country, can we afford not to look at housing and the implications that has for health and well-being? Similarly, around economic inactivity, which again links to lots of previous discussions. The working age population is the biggest population group, yet we've never actually done a JSNA on the working age population. And the focus that's been brought on this is economic inactivity, which links very clearly to mental health as well, which being one of the biggest causes of economic inactivity. And how that's impacting on our local area and the increases we've seen in economic inactivity, I think is one of the reasons why it was put in as a priority. The third one around health inequalities. We look at health inequalities, it's embedded throughout all the JSNAs, but we've never actually looked at it across the system and the cumulative impact of different inequalities. And that's a really good opportunity. Now, we've done so many JSNAs, so it's actually picking up again on the synergies and common themes. And lastly, we put in women's health, which perhaps might slot into the health inequalities. A lot of airtime women's health being given at the moment in terms of inequalities, and these being flagged out in various reports. And that fits with the focus on women's health generally, women's health hubs, which there has been some funding coming into different systems to take that work forwards. So in terms of picking those out and prioritising them, it's very much picking up on it's a system-wide issue. That they're present strategic drivers, and there is an opportunity to bring added value as working as a system. And I think that is the key to JSNAs. They bring added value because they are areas in which impact on all organisations. So therefore, it's kind of, what's it, greater together and separate, whether that phraseology is, but certainly working together on these areas would really be kind of a criteria for prioritisation. The next key theme in it is the JSNA process. Obviously, for the past few years, we've worked, well, a number of years now, we've worked with a shared health and wellbeing board, then that transformed into a committee in common, and we've had a JSNAs have been done at a system-wide level. With the kind of production of JSNAs has always been taken forward by the public health team, working with a whole range of partners in different organisations. But obviously we've separated the public health teams, and I think the board has informally said we'd like to continue with a shared JSNA, but it's more about the formal approval of that approach. And it also affords the opportunity of the JSNA process in terms of its development, to make sure there's a standardization in the approach in terms of consultation with partners, when partners are brought in, taking it to place boards, for example. So it's that opportunity. And obviously we are learning to work together as well as a separated team, but coming together with these system-wide areas of work. And it's that opportunity to develop the process and perhaps look at how we present JSNAs as well, to ensure that they maximise attraction. An awful lot of resources go into producing JSNAs, and I suppose we want to ensure that that resource is well used, and therefore I think how we can present it in a form that presents a very visual image, for example, increased use of infographics, just simple things like that, that you can summarise an issue in a very visual way. And then the third thing, of which has probably been the theme of the morning to date, is that's great. We presented sort of some recommendations here in these two JSNAs, but it is the recommendation, which I think you've endorsed already, is that they are taken forward, ideally perhaps in a board development session, in terms of looking at the criteria for prioritisation, and then what are the synergies in the system across those priorities, and where those synergies can be exploited and developed further. And I think probably that the start would be the board development session, but there are other groups as well where this can be explored and developed and taken forward. And then there's a very practical recommendation, a very kind of sitting a little outside this was, there's currently an older people's needs assessment nearing completion, and whether that becomes a joint strategic needs assessment, which would be brought here, which if you think of the criteria of it's a big pressing priority in terms of the costs to the system, which have been predicted over the next 10 years or so. So a JSNA, and this needs assessment, looking at it through the lens of a JSNA in terms of its impact on the system and what the system could do to mitigate those impacts, is why this recommendation has come here, that the needs assessment becomes a JSNA. So to summarise, those are the recommendations. I hope they resonate with you in view of your previous discussion, and I'll leave it. Please, any questions?
Val, thanks very much. So I feel almost it's sort of a natural extension of what we've said already this morning, that the two of your recommendations about impact and effectiveness is something that we would endorse, and also that connection to, how across the system we prioritise and sort of work with those and shape the work of the board. So I think almost those two are taken as read, but I guess we do need to say, are these the right ones that for the next phase? And then there's a couple of very specific points about across Cambridgeshire and Peterborough, and also the older people's one. So views, people, any views on all of this? Louis, first of all.
Thank you, Val and colleagues. I think it's really helpful, and I think it would really help us going forward. I was going to suggest or ask a question really. If we look forward in the next 15 years, the way that our population will age is going to drive very, very, very significant demand pressures for us as a health and care system. And I suppose I was just that last comment you made around, actually, do we need a focus on that and make that a JSNA, I think would be incredibly helpful. I'm also very conscious of the resources at the stakes. And I'm very struck by the comments this morning around sometimes understanding not just the needs assessment from the population point of view, but also the service needs assessment that sort of kind of accompanies us, that could really make it meaningful for us then to kind of assess that. And I wonder if we could maybe do that. And I suppose there's a question alongside that, which is, do we need to deprioritize anything else in order for us to have the right priorities in the right way back here? And do we need to have a conversation about that? Because if I had to deprioritize something, there's a question around inequalities for me, because I think we've got a lot of information on that, but I can completely understand why we would want to do that. But I feel like all agencies have a lot of information, and it's what we do about it, really, that's the important thing. And then a question around sort of the women's health, whether we want to prioritize that given what we know is coming.
Yes, I would agree. I think in terms of going back to the discussion just now about action and taking it forward, making the recommendations meaningful to services helps them helps inform their decisions about how they develop their service, and of course the underlying resource allocation as well. So I think I think what you're asking is that becomes part of the JSNA analysis, and also that modelling forward as well, which is so critical at this moment in time.
Thank you, Sally.
Yeah, thank you. Support Louis' comments, and just building on that as well. I think whatever we prioritise to take forward, I think we can really, as a partnership, think about how to make it really work for us. And there's something about making it almost a bit more punchy, kind of honing into what is actually really useful, more visual, more kind of targeted into the population that we're talking about, so that when we're looking at them in this meeting, it's easier to see what is it actually going to drive, what difference is it going to make, how do we know where to target because of what work's come through. So I think there's probably a piece of work outside of this as well to say, if we decide on 2 priorities for next year, for example, what actually do we want that to achieve for us, and how do we make it really snappy and kind of hone in on the important information for us.
Kate and then Patrick. I'm conscious we are running a bit behind, but Kate first.
So super brief then. I think any prioritization conversation we have should be coupled with the delivery conversation, just so that as a group we are clear on who we are tasking with the work, and then what we're expecting back by when. Really boring practical points, but I think we could spend a lot of time prioritizing.
Kate's pinched my line. I suppose my question would be is for all of these pieces of work is so what? So we could pick 2 out, and we can get those huge piece of work done, huge resources, big commitment of time, lots of people's skills and specialisms. We bring it here with a list of recommendations and priorities, and then 15 years later, Neil's point is that we're still sat here saying we've got these as a priority. So I think the deliverables, the focus of the delivery and the holding to account, to use the JSNA to say this is where we were and this is where we are now. So you've got that trajectory and you can see that movement. I think that's where the value of the JSNA does. We can keep producing JSNAs which highlight the areas of priority and the list of recommendations, but it's the way that we address them that's the that's the focus. And with Louis around the kind of tsunami for older adults, but I just wonder around JSNA for older adults whether what will it tell us that we don't already know about this huge demand of pressure of services right across the system from the growing population that we see and an aging population, and so I think we've got to think about how do we use the JSNA as a tool to both inform but also hold to account, to help us to hold to account for delivery.
Just going to take Neil and then see where we are, Neil.
I would say my 16 years, I miscounted. Things have got better in many areas, so it's not to denigrate actually the important work that happens here, but I think it is for me. If the NHS, as part of this, is moving towards a neighbourhood mentality, which the councils have been in for a long time, then actually it is that practical bit of actually as a GP practice in Peterborough, what is my role in helping the Health and Wellbeing Board and ICB actually deliver the objectives that it has? And I think that is the conversation that we've just had, isn't it? And if the other frontiers are artificial intelligence, technology, digital, then actually how are we holding our toes to the fire to say that actually Cambridge and Peterborough wants to lead in some of this stuff? We don't want to be laggards in this agenda, so therefore our system should be monitoring what's happening there, not as a stick to beat people with, but actually as a challenge to us all to make sure that we are innovating in those directions.
So Val, I think there's lots of helpful suggestions about the sort of nature of JSNAs and sort of how we improve visibility, impact, how we link them. So I think we can collect all of those. Do you need us to prioritize those subjects today, or are we effectively, I mean, because clearly there's been sort of views about inequalities, women's health and the like, or is that a list you're prepared to absorb some of the comments on and reflect on?
I think the list was proposed as a number of JSNAs that perhaps have a need in the system at this moment in time. I think the more important thing is the time frame for them, because they could be undertaken, but 4 in 1 year. We normally plan ahead for a year. Admittedly, I think mental health was so big it took longer. So I think yes. I suppose the first question, do you endorse the 4 areas? Then I think it would be within that, would you prioritize in terms of time?
Okay, so I guess we need to sort of agree that those are sort of all core areas, but we need some further guidance on what the priorities would be. Can I just check whether let's just deal with one of the specifics about carrying on with the shared arrangements across Cambridgeshire and Peterborough for joint JSNAs. Anyone want to speak against that? Assuming that people have agreed that before. So that's, I think, taken as read, as well as the improvement points. So on those priorities, Val, is it that you will come back to us with actually of those, these are the ones that we think are the most important, and in what time frame, and that's part of our March conversation?
It could be, yes. We could look at the resource implication. I think there's still a lot to be done in these 2 big JSNAs that come here. We have the older people's needs assessment as well to bring here, or JSNA hopefully, to bring here. So we could look at the resource implication and work out a timeline and some prioritization in terms of criteria. I think there's kind of, it comes back to the discussion earlier. There's so many synergies across even these 4 as well. So I think we can do that, bring it back to the next board meeting with a prioritization based on some clear criteria which have been brought forward here.
Yeah, I just feel we need a bit more help to land that, really, than sort of shooting too much in the dark this morning. But people have given various steers, but I'm not quite sure, how we would land that without some of that criteria.
Yeah. And it might be useful, perhaps, in view of the previous discussion about it goes to areas like the place boards, for example, for their views as well, if that board would be agreeable with that, or a survey or something like that.
Okay, I mean, I don't want to sort of hold this up
Yeah.
I'd sort of like us to land this in March, but I'm just sort of, I'm just conscious we need something which is firm as a sort of proposition. I'm just going to take Mike, and then I'm going to have a break. Mike.
I just wanted to come back to a point that Sally made, which is that we probably want to make these more punchy. And so I'm keen that we don't set the programme in stone before we've had the discussion in March about how the board is going to use JSNAs going forward.
No, I think that's important point. Go on, Stephen. But
Very, very quick, just to follow up on that, is there a different way of doing it? So do we need to, the resource, I think that you've mentioned that takes to write it. I know other areas are looking at having the mechanisms to update the data as we go and do it in a very kind of different way that doesn't require the resource of writing a JSNA. I feel as though we're in a very different time now in terms of, and it's quite a traditional way of doing it. So I think there's an opportunity to relook at what do we need as a system that's probably a bit more real time and that we can use to kind of inform implementation plans, I think, going forward.
yeah, no, I think that's absolutely inherent to the both some of the stuff that's in the paper, but also the conversation we've had this morning, that we need to reflect on sort of how we're doing them as part of the sort of improvement agenda. And then we need to, as Mike says, reflect in March on that short list. But Val, thank you. It's really helped to catalyse some of that. So could we sort of slightly shorten our break and perhaps take 6 or 7 minutes and then try and head back at 20 past to do the second half? But thanks for all of the help this morning on the JSNA points. Thank you.
It was weird because like I mean, if hang on a sec.
Yeah.
Exactly. Sorry? How's that?
Okay, colleagues, if we want to reassemble. Right, thank you very much. We are on to item 7, I think, which is around pathway 1. We've got John Rook from the North Place who's going to present, but I know that Steve Taylor and Patrick and others and Holly are here to pick up any questions as well as John. So John, over to you.
Thank you very much. So I am here as some sort of glamorous frontman for this rock band that I represent, which got Holly on drums. So Holly, do you want to introduce yourself?
Thank you. I'm Holly Sutherland, Chief Operating Officer for CPFT.
And then I've got on bass and lead Stephen and Patrick, who you know as members of the committee. And we have 3 sponsors of this particular piece of work as the providers of a good majority of the existing pathways in Holly, Stephen and Patrick. And the work we brought you is a representation of a broader cast of people as well. So very much reliant upon the input of the voluntary sector in their role in effective discharge and intermediate care, as well as our hospital trusts and broader care partners. And this paper today is for an integrated care partnership. We bring an operational challenge, but alongside that, we don't want just to overburden you with a big hole in the ground to try and solve here and now. We bring you an integration opportunity. So we have started to look at how we could address some of the challenges, which I'll go through in a second. Before I do that, I just think it's worth saying that when we talk about some of the challenges and problems we've got, it's really important context to say we're actually building on some really good progress across health and care teams working together collaboratively on discharge, and pay tribute to the work Sabina's led on behalf of the integrated care system to bring people together through our transfer of care hub to try and smooth pathways for people when they need to be discharged from a care setting. But also to all those health and care professionals who, while we talk about challenges, not to denigrate, but also to celebrate the good work that they do every day to keep people safe and drive their outcomes. So what we started to look at in this work is we've got a particular issue for our residents in that at the point when you are probably at your most vulnerable or close to it, you've had some unfortunate acute illness or episode, you've been transported to hospital in an ambulance, you end up on a ward with beeping going on all the time, and then you're starting to think about what the implications for the rest of your life, not just for you, for your family, your support infrastructure, and getting that part right with the right support is really important. And we don't do that always. People stay too long in a hospital setting, and we too frequently make decisions with people, or sometimes, unfortunately, on behalf of people, when they're in their sort of lowest ebb, when they're in the acute phase of their illness, rather than going for best practice models and saying, actually, how do we take you home? How do we stabilize and support you? And then how do we help plan for your future? So Pathway 1 particularly looks at that element of where we take people home and we support them with home-based care and support with ongoing decisions around how they are going to support their needs in an attempt to maximize their independence. So it's really, really important for residents. It's really important for staff, because staff say that actually, as they try and navigate some of these pathways from hospital to community services to social services, it's quite confusing. There are lots of handoffs, and they feel delays in the way they do their work. The diagnostic work we've done highlights quite considerable gaps in our capacity, and you can look at different services for varying degrees of that. What we've seen is that the demographic change outstrip our supply, and we've not grown it as quickly as we could. And the even more alarming bit is a forward look about how the demographic change will make that more problematic. So as a integrated care partnership, we have a capacity issue as well as a process issue that we want to address. And just to summarize that, we effectively have a pretty disintegrated model of service delivery, and we're non-compliant with national standards. So for all those reasons, we've diagnosed that properly to say, actually, how do we think about doing this better? So for the integration opportunity we've said with our sponsors here, actually, how do we look at best practice? How do we think about future demand? How do we look down the barrel of the very challenging affordability pressures that this brings and will bring to partners around the table? And to say, actually, how do we co-design a model we think will be better for residents and staff? So that's the process we're in now. We doing that with the best intent and the best spirit. It will be intended to be agnostic about who funds and who delivers some of this. Actually, we want to get the right model for residents and staff first and foremost. And then I think for the Health and Wellbeing Board, for the Integrated Care Partnership, we'll need your support, because there will be some challenges. There'll be some challenges around sovereignty of organisations and employers. There'll be challenges around funding and where that goes and where that should go, including growth in funding to solve some of the issues. And there'll be challenges particularly around attracting the right workforce. What this indicates is we need a significant increase in number of therapists of various types in our system to respond to the demand we have. So attracting, retaining and training that workforce will itself be a challenge for us as a system, but a most attractive package for people is to work in an integrated model that is a resource to do the job required of it. And I think finally the most challenging issue would probably be a culture, the culture between the different organisations in taking on some of these challenges, thinking about how it is to work in a more integrated way, think about dual skills and roles and functions within this, and across traditional borders as well. So we look forward to bringing back some of the solutions and your support with addressing some of the challenges inevitably we'll face, and support us to see through to implementation a new future-proof model of Pathway 1.
Thank you very much, John. Just before we get questions and comments, just give us a sense of timescale and trajectory on the work.
So we've completed our diagnostic phase. We're now in our design and development phase, and we're taking a little bit of time with that because we want to make sure the right people are involved. We want to make sure it's evidence-based and supported. We want to look at best practice models, including site visits. So over the next 3 to 6 months, we'll complete that work. And then we'll be saying, actually, what does this mean for us in terms of financial resource, workforce, and those implementation timelines? What we're very conscious of is we don't want to hit implementation with no financial planning, for example, no workforce planning. So we're concurrently running some of those at the minute to say, actually, if we were to start something in 25, 26, if we were to build some of this infrastructure, or at least address some of our capacity gap in terms of workforce to start with, actually money would be set aside. That's part of the financial planning for 25, 26. But I would hope we would have a blueprint for our new model in around the autumn time for then hopefully some rapid implementation of those elements.
That's helpful. Thank you. Mike, did you want to come in? No, sorry, I thought you were signalling.
Yeah, sorry, if there's nobody else immediately wanted to come in, I've sort of been thinking a little bit about this. In these meetings, there always seems to be a desire to get people out of hospitals, and often it's back into care homes. And that's something that's worried me for a while from this. I mean, my experience of it when my mother was in a care home and was that she was desperate to be in hospital and to stay in hospital. In hospital, she was looked after properly. She never had any falls. The bedpan always came in on time. When she got back to the care home, she was in an environment where the bedpan didn't come in at the time, where there was chronic understaffing, and where she was inevitably going to be dropped again before too long. And I noticed this paper says that one of the biggest reasons for unavoidable admissions into hospital is falls. And I mean, the elephant in the room here is we are funding a system where it is chronically understaffed, where some of the companies involved are taking our money and stashing it away in the Cayman Islands, and people are routinely dropped by staff who are underpaid, undertrained, and not respected. And there's a sort of systemic problem that I see here that goes a long way beyond the sort of thing we're talking about here. And the other question I've got on this is this a moving of work of assessing what people need from the NHS into the social care system? And if we do that, is there a danger that we'll be looking at it and saying it's going to be privatised to do that? I mean, is there any element of privatisation in the proposals we're looking at? And if we do get these companies involved, we're talking about integration, but we're moving things outside our direct control and into an arena where the main considerations will be commercial rather than the well-being of the people we looked after. So I hope that's helpful and is to the point. But
no, thank you, Mike. And some of that I take as a sort of comment, but there is a specific question, John, you might want to pick up, and then I've got Stephen and others. John.
So the aim of getting our processes right for people when they leave hospital, or even preventing them to go to hospital to start with, is home is best. And that's either home with no support because you don't need it, or you're getting that from core services for the vast majority of people. When people do need support, try and optimize that at home, because we tend to get the best outcomes of people if they're safe and able to maximize their independence for as long as possible. So that's the aim of this. For those people who need some support at home, get them out of hospital, support them, and build their future plans for the future with them, whatever care needs. So what we're really keen not to do is to make decisions when people are at their illest, and then end up with going for overprescribed solutions, particularly care homes or bedded facilities in the NHS, when actually they don't need them. With support at home, they'll be much more mobile, much more likely to regain their independence. So it's designed particularly with that. We have no plans regards to the Cayman Islands. We have no plans to particularly consider outsourcing this to private institutions. The current employers of the majority of staff who do this are in the councils and in the NHS. So I think, first of all, looking at between those current providers, how can we provide a new, more integrated, joined-up model with greater resource and greater proactivity around home-based, in most cases, therapy-led care.
Thanks, John. I've got Stephen, Neil, and Louis. Steve.
It was just 2 points for me, really. I think in support of what John said, really. I think this is always a notoriously difficult area to work on cross-system, across kind of system partners. It can be quite complex area and can be quite fraught, I think kind of quite often quite financially fraught across organisations. I think firstly we should just kind of pay tribute really, I think, to the work that's been carried out so far, because it feels as though it's really been a kind of really thorough piece of work that I think has engaged each of the agencies involved in a really thorough and really good way. And I think each of us were able to kind of come together and really agree with those findings, because I think we all feel that we've kind of owned the findings, we've owned the research, we've owned the process that's being carried out. And it's a shame really that Sabina isn't here today, who's really done that in such a kind of a good way. So I think it's meant that we wanted to come here, I think, today, didn't we, as key partners together, to say that we kind of own this approach and that we're committed to kind of moving forward and delivering this. I think the second point really is about that bit around, you know, we need to kind of deliver it now. We need to do the work together, and we need to really kind of push on in terms of delivering it. And again, I think we've probably got quite a bit of fraught work to do. We've got quite a bit of complex work still to do. So there's that bit around, it feels as a system, it gives us the basis, doesn't it, in which to move on together. And I think really get a win as a system in terms of delivering something kind of quite substantial, because it feels important to us as a system that we do get some wins and that we do work together and that we get something that we can almost like relationship build further and then build on, I think, going forward in terms of other areas. So really just those two bits to praise the work that's happened so far, and I think to thank Sabina and partners who've been involved in it. But I think just to kind of be aware that it's going to be difficult moving forward, and you know, and I'll test the partnership moving forward, but I think it's something that we really need to do.
Thanks.
To be able to develop further with that.
Thanks, Steve. So a gain to be had, but not without pain, I think. Neil.
No, Steve's just articulated it. I think, you know, these kind of knotty issues that are financially fraught, you know, different organizations will view it in a different way. I love hearing about things like this, because I think this is the kind of thing that we need to tackle, isn't it? So we think about new models of working, new models of care. You know, actually, this really holds our feet to the fire, doesn't it, in terms of when it does impact the way that our organizations normally work. So thank you very much for sharing your work.
Louis.
Thank you. First of all, just sorry to hear about the experience of your mum. I think I think we need to acknowledge that this is done on a sort of a case-by-case basis, and as John said, home is best is our kind of narrative, but actually will always be looked at an individual level and working out whether that is in fact the best for the individual involved. I think there is a lot of evidence that talks about how patients decondition in hospital and why that's not good for them. In the sort of longer term. And I think there's a lot of evidence to suggest that actually by discharging patients home or to their preferred setting, actually it has an enormous amount of health benefits for them. But I think the other side to this, unfortunately, is also that our acute capacity is quite constrained, and that we also want to make sure that the patients who need that emergency care and the emergency admission, you know, we are able to accommodate them on the other side. And that's why this work is so important. But it is, as John said, to expand and to make sure that we are discharging patients safely and in the right way by working together, I think is fundamentally the point here.
Thanks, Louis. I've got Patrick and then Liz. Patrick.
Yeah, thank you. I suppose just to support the paper and recognise the work that's ongoing. I think there's also some honesty in that it's a partnership. There's been difficult relationships, and I think we're actually addressing those. And I think we've got to be honest about that in order to overcome some of the challenges that we see here to get it done. There's two things. One, I always think the success of a partnership is where you recognise that for the greater good, sometimes the money shifts away from you and into somewhere else. And I think we've got to get to that place where we feel comfortable and recognise that that's an important stage of moving resources around in terms of tackling and supporting people, because you know, people need to be at home, and the care and support that we give people at home is the right place, wherever that home may be. The bit for me is just focusing on pathway one, and I've said this before, doesn't feel the right way. There are other pathways out of hospital, and I think as a system we've got to consider all of the pathways, because as you naturally start to tackle one pathway, you usually stray into other pathways, and I think there's an important concept that we need to think around the different pathways out of hospital and how we address those. I think the other thing we've got to think about, which will naturally flow from this, is to stop the circular route of back into community and back through the front door into the acutes, is how do we shift this to a locality and a community focus, particularly working with primary care and some of the community services that we need to strengthen and maximise to make sure that we've got the right care for the right person in the right place, so that we don't just see the open door of an A&E department as the way that somebody can then be receive treatment if they reach a point of crisis. So I'm fully supportive of this paper.
Thank you. I've got Liz and then Julie Farrow, and then we'll bring it to a close. Liz.
Thank you, and through you, Chair. I thought it was a great paper. Thank you, really interesting. And I particularly like the stories of people and sort of really brought to life people's personal experience, which I personally found very helpful. Just one thing to add on your slide on current funding streams. I don't know if you talk to any districts. We're spending £150,000 a year on mobile wardens, which is a service that people can pay for, but we subsidise it. And I know it's a tiny drop in the ocean compared to the 14 million that's on the top two lines of that table, but it does feel like it's an important part of a jigsaw. So maybe you want to talk to the districts about what we're doing.
Thank you, Liz. That's a really good thought, and we should pick that up. Julie.
Thank you, Chair. Thank you very much for the paper. I thought it was really good. It was well laid out. Like Liz, I like the stories. I think my question is about the fact that actually the Voluntary Sector Network, Voluntary Sector Alliance is part and parcel of Pathway One. Obviously, you're talking about the issues that are in the house within the hospital system rather than in the community. And I just wonder, like Patrick, what other things we could look at that actually would take things out into a different area. The voluntary sector does such a lot in the community, as does district councils. I'm not sure we're maximising everything that's out there already, so we need to really look at that. And I wonder whether that could be slotted into your next phase revolving around when you're, evaluating things. But it was a super paper, really well laid out, and I'm very supportive of it.
Thank you, Julie. Holly, do you want to just respond on those points? Thanks.
Yeah, thank you. And thanks, Julie, for raising that. And I think throughout the Home First Programme Board, the voluntary sector are a really important piece of that puzzle. At the moment, we're trying to maximise how we use the voluntary sector to support our Pathway Zero discharges from acutes. And we know that we've got some really good engagement in terms of supporting those individuals. I think we will, at some point during the Pathway One work, look at actually how do we ask our voluntary sector colleagues to enhance some of the support that is going in from both a health and social care aspect. But just really want to sort of reassure you that the voluntary sector colleagues are well and truly embedded in the Home First Programme Board, which has been leading this piece of work. And I guess whilst I've got the mic, Chair's privilege, I too would like to just endorse this paper. Pathway One has been a really complex issue. Every winter it raises its head as an area of as not getting it quite right, either for our acute colleagues or more importantly for our patients. And every year we're trying to sort of, I suppose, do short-term things to try and improve the situation. And actually, I like Neil, have been in the system for many, many, many years. And I guess this is the first time that I've seen all parties involved in delivering Pathway One say, we can't go through another winter like this. Actually, we all want to get this right for the staff and for our patients. And for me, that's a really significant and very positive difference.
Thank you, Holly. I'm just going to take Susan, then bring us to an end on this one. Susan.
Thanks. It's great to hear the voluntary sector involvement here, and also from Liz on behalf of district councils. I just wanted to say, it seems to me that with both those parties plus the ICB's work in the community, I certainly see a new sense of moral responsibility at parish council level, actually, for saying social care and the principles of Pathway 1. This is our business too. And not only is the district council subsidizing the mobile warden services, but more and more parish councils are saying, okay, we can afford to support 3 clients a year or whatever. And I think that's an incredibly important cultural change. Some of it dates from the excellent work of public health and district councils during COVID, and it's been great to see.
Thank you very much, Susan. So, John, you said it was an opportunity, and I think we take it as that, as an integration opportunity. But I hear the point you and others have made that you know, it will be bumpy at times. But Patrick's point about sort of honesty, about needing to get back to that point, I think is something we should take as we go forward to it. Take the points about, you know, this may lead to looking at wider pathways. We should certainly think about the link to place and locality, and you've I think absorbed the specific points on district councils and VCSE. So people happy to agree the recommendations? Thank you very much indeed. Thank you, John. Thank you, Holly, and thanks for the support from Patrick and from Steve, and we'll pass on our thanks to Sabina as well. So can I invite Caroline and Sandra to join us? And I think Lisa is on screen. We've probably got 20, 25 minutes for this and our pharmaceutical needs assessment items. So this is the Better Care Fund Q2 report. I guess just with that idea that we may have to be reasonably focused on time, but Caroline, Sandra, Lisa, over to you.
Thank you very much. I'll keep the overview relatively short, bearing in mind we have got quite a tight agenda slot. Just to update on key performance for Q2. This is obviously based, as is usually the case, on the data for the quarter previously. So although this is Q2 return, performance in here is up till the end of Q1. So it gives us an early indication of how we're performing against the 4 key national conditions relating to BCF. Overall, at the end of Q1, we're seeing probably a similar picture as we were at the end of the year, kind of continuing through into this year. We've got good performance, and we're on track to meet the target around discharge to normal place of residence, and also to our residential admissions, which again we were performing well on last year. We are seeing a slower realisation of benefits in relation to admissions, avoidable admissions. So they're not on track to meet target at the moment, but we are starting to see some slow improvement in that area, and equally with falls admissions. In terms of capacity and demand, which we had to provide an update on how we were performing against our capacity and demand modelling. Actual demand has very much mirrored what we had forecast, which means that we have been quite accurate with the forecasting. The key areas just to note very much are, though, in relation to Pathway 1, where we've had lower demand than what was forecast, and that's predominantly due to a change in the way that we are reporting with Pathway 1, and also due to some lack of capacity in that pathway, which has obviously been picked up in the previous report. On the other hand, we are seeing increased demand due to improved capacity for voluntary sector support, which is really positive, and that's as a result of the investment in the single discharge, voluntary sector discharge hub, which is starting to kind of come to fruition with that additional capacity.
I just really quickly wanted to just provide a really quick update on what we know so far around BCF for 25-26. We are waiting for the planning guidance, which we are hoping will be arriving in the next few weeks. What we do know from the provisional LG settlement to date, though, is that discharge funding, the local authority discharge funding, will be continuing at the same rate into next financial year, but it will be rebranded and merged in with the Improve Better Care Fund. So it will, the two together will become the Better Care Grant. So we don't know what the exact conditions around that are, but we do imagine that will give us a little bit more flexibility. And we've also had an in-year increase for the Disabled Facilities Grant, which we are expecting to continue into next year at the same rate. I'm just going to let Sandra update on the NHS funding elements.
For the health element of the discharge fund, it's been indicated that the discharge fund will be amalgamated into the core BCF allocation, and also the ring fence on use for discharge will be lifted, so that means that funding would be available for any other schemes that we wish to fund. So that shift seems to indicate that that funding will now become recurrent funding, rather than we were expecting maybe that may expire because it was non-recurrent funding previously. There's been no indication currently of any uplift for 25-26. So I think at the moment we work on the basis it's the same levels as we have this year.
Thank you. And any questions that people have got about the report and the return? Just one point in the report was really, I mean, not for now, but the predictive analytic work on falls seems sort of really interesting. I know other people have done some of that, so I'm sure it'd be good to sort of hear some more about that when that's a bit further down the line. So I thought that was definitely worth us having. Lisa, anything you wanted to say? No? Okay, thanks, Lisa. So we are asked, I think, to approve the Q2 returns. People happy to do that? Thank you very much. Thanks. Thank you, Caroline. Right, Ian. Pharmaceutical needs assessment. Over to you.
Thank you, Chair. So we're reaching that time of the year again. I come back to this board every 3 years with a P&A update. For those of you who don't know me, I'm Ian Green. I'm the Service Manager within Public Health at Peterborough, and I'm also the Chair of the P&A Steering Group, which is the steering group that delivers the P&A across Cambridgeshire and Peterborough. So the report is more of a process report. It's to update you on the progress so far, but more importantly, to get approval from the board to produce one P&A across Cambridgeshire and Peterborough. Although we are a committee in common, the legislation does not recognise that. So technically the P&A is one for Cambridge and one for Peterborough, but we've always produced one across the system. And if the board wishes, we will still produce that across Cambridge and Peterborough rather than having two P&As. But more importantly, the P&A never fits in with the timescales of when the board meets. So we're asking for delegated approval for the chairs along with the DPHs and the steering group to approve a draft P&A for publication by the end of September to meet the statutory deadlines the board has. But knowing that the board has an investment in the P&A, we'd offer a workshop to members to discuss the P&A in more detail prior to its approval, that would sit outside the formal board structure, but would be a workshop that we'd organise in Public Health on behalf of the board to get that wider engagement. I think it's worth reflecting that this will be the first P&A produced with the ICB having the statutory responsibility for commissioning pharmacy, because last time it's happened with NHS England. So I think it's important that we get that wider engagement, and we also need to engage North and South Place, I think, in this, because it's such a key focus of how we deliver services going forward that wasn't the responsibility of the ICB previously. It was NHS England's responsibility. So I think it's worth having that wider discussion about making sure we have the right partners around the table inputting into the P&A. So in terms of process, we in public health hold the ring. We will make sure the P&A fits with the statutory requirements. We'll make sure it's done on time. We'll look at the services that are available now and where the gaps might be. I think it's also worth reflecting on the substantial changes that have happened to pharmacy over the last 18 months or so. We've had significant closures of pharmacy. We've had a significant reduction in opening hours of pharmacy as well. And it's important that we acknowledge that and make a good, robust assessment of, do we think the current pharmaceutical provision across Cambridge and Peterborough still meets that demand in the patch and where possible. Because obviously the P&A is used as the key document by commissioning bodies on whether a pharmacy can open or not. It's not a responsibility of the board, it sits with the ICB. So it's an important key document that facilitates that conversation. But happy to take questions from the board.
Thank you, Ian. And just one question before we open it up. If we were to do the workshop, that would be sort of what, autumn, are we saying, or a bit earlier than that?
So it depends on timescales, to be honest. We'll make sure we fit a date that meets the board's requirements, but also gives enough time to take any findings of that workshop into the final P&A. So as I said, the P&A must be approved by the board or by delegated authority by the end of September. So hopefully we'd have a workshop probably a month at least before that, so we can take the findings of the board and tweak the the P&A if we need to.
Thank you. Questions for Ian? Kate?
More of an offer of support, really. This is now my portfolio from the health perspective, so I'll look forward to working with you on it. And I think just acknowledging just the significance and importance of our pharmacy colleagues and the context within which they're operating at the moment. I think it is a really important piece of work, and I think it's really important for us as a system that we're having those conversations and looking at that evidence base in the context of what we're trying to achieve collectively, especially around developing a new model of care and a different wraparound approach at place for our patients as well. So looking forward to working with you, Ian.
Thank you, Kate. And Louis? Oh, sorry. Shabina, do you want to go first? Okay, sorry.
Thank you. Just a quick question. I agree with what Kate just said. Are we going a bit further and also understanding some of the enormous opportunities that we've got around pharmaceutical capacity within the system, thinking about new care models? Is it just a review of capacity, or is it actually saying, look, you could go further in terms of maximizing opportunities? Is the question. So it's presumably what already sets out, but I just wanted to know.
That's always a tricky one. The P&A statutory document is governed by the regulations of what should and shouldn't be in the P&A. Basically, it's an assessment of current need, but also that needs to be based on the model of services that are delivered within it. So we have opportunity to look at what we do now in terms of service provision, but also what should we do in the future under the model of care, so we can do that. I'm also hoping to get one of our registrars to look at more of the methodology around when is it appropriate to open a new pharmacy. Because obviously the number of pharmacies we have, it tends to be governed by the capacity and the number of houses on the ground. With the significant growth we're having, particularly in South Cambridgeshire, there will be a question about when is it right to open a pharmacy in Northstowe, for example, when is it right to open a pharmacy in Waterbeach, and that's not an exact science. So I'm hoping that the registrar will do a bit more methodology around to support some of that conversations, because the danger is we'll produce a P&A in September that says we're okay, we're still within the averages across the UK, and we don't need any new pharmacies. But at some point, there'll be a break point when actually it is okay to open a pharmacy in Northstowe, and we need to work out, and all the growth sites come to that, we need to work out exactly when that point is hit.
Shabina.
Thank you very much, Chair. I can't tell you, and this might sound really silly, but it's a personal perspective, how challenging it has been to try and fight for pharmaceutical services to serve a population or anybody that wants to open a pharmacy. Now, the previous pharmaceutical needs assessment is always taken into consideration by our commissioning colleagues. And if I'm not wrong, the NHS arm of approving of commissioners sits somewhere in Essex. And I'm just going to cite a recent example. Since the previous PNA, we've seen numerous pharmacies close across the region. We then have government legislation that comes in since then that stipulates that services like pharmacy first, etc., are going to take the load off primary care services, which is fundamental in easing the pressure off primary care. Despite all of that legislation in place, it has become inherently difficult for pharmacists to open pharmaceutical services within a city. And the reason being that our previous PNA has since not been updated until now, obviously, and a body that sits outside our region, on the other end of the region, states or evidences that the reason why we don't need a pharmacy in a particular locality is because, number one, the PNA doesn't stipulate it. And the second thing is that they take data such as so many people drive a car in that area, so are able to get to a pharmacy 2 miles away, but doesn't look at the socioeconomic deprivation, the mobility or population of people who are over a certain age. And I feel that those are really important factors. So I really hope that whilst we have these workshops, those are things that can be taken into consideration. I look forward to working with you on that. But I needed to express that frustration because it just seems as if there's so much red tapeism involved. And our pharmaceutical colleagues are fundamental to making sure that we see services run efficiently, especially in primary care. I just need.
Yeah, thank you, Shabina. Point well made. I think that the issue we always have with the P&A is it takes an average across Cambridge and Peterborough and it compares it to the national. So, if I was to look at the P&A probably 3 or 4 times ago, so that's 6 years ago, we were just about over the England average in terms of 22 pharmacies per 100,000 population. But that's across Cambridge and Peterborough. It's not nuanced enough in terms of the difference between a rural area, a dispensing GP, and more of an urban area. So it is quite a blunt tool. If I look at what's happened recently, we're still within the national average, but we're down to about 16 per 100,000. But that's because nationally we've seen closures as well. So once again, we lose the nuance in that picture. I think it's really important that the P&A looks both at travel time, but also locality and any deprivation that goes with it. We haven't done that previously. What we've looked at is basically what's the access time by foot, by cycle, and by public transport. But we know there's been changes to all of those over the last 2 or 3 years, particularly public transport. And we've assumed that a travel distance is the same for everybody, and it's not. If you don't have access to a car and your bus service has been cut, then you can't access pharmacy services in quite the same way. So I think this P&A needs to look at that in more detail. We haven't done that in previous years.
I think, therefore, we're being asked to note the progress on the production of the P&A, that the format will continue to be, as Ian said, a joint P&A across Cambridgeshire and Peterborough, but technically, of course, one for each, but in effect, a joint assessment. You're being asked to delegate approval of the final P&A to the directors, the 2 directors of public health and the joint chairs of the board. And I think from the nature of the conversation, Ian, that people would welcome the opportunity to sort of come back to some of the challenges that people have raised as part of a workshop, some of the points that Shabina's made, and Kate and Louis. It would be good to actually think about those questions in the light of where we get to in the late summer. So are the board happy with those recommendations? Thank you very much. Thank you, Ian. And then finally, I think on any other business, well, we've talked quite a lot this morning about this sort of, we've got some time on the 7th of March for wider development. And I think we've got Kate Parker has been working to get some help on that with learning some lessons from other health and wellbeing boards. But there's some very specific questions that came through, particularly in the first half of our conversation this morning, about how we operate. And I'm sure the chairs will have some conversations both with Sally and Mike and Patrick and Kate about how we take some of that forward in March as part of that wider session. And we have got a formal meeting as part of the 7th of March, although, so I think we're going to probably try and allow a significant amount of time for the wider conversation. We've also then got a series of dates which are on the agenda for meetings for the next year. So if people are happy to note those, thank you all very much. Thank you very much for your time and attendance this morning, and look forward to seeing you soon. Thank you.